to start your weekend early tomorrow. So.
I was thinking that.
Okay. Yeah.
Leave early.
Oh,
Yeah.
that's much better.
Okay. That's what usually is. That's like.
Okay, all right. I think I will start now.
Because.
I think it's a good time. All right. Okay. All right. Hi, everyone. I think the residents know me. For the med students, I'm Hiba. I'm one of the PGY 2s. Nice to see all the faces. My journal club today is on the Artemis trial. It is an IBD trial. And so we're going to kind of build things up from scratch. So I want to lay a nice foundation and just talk about IBD for a second. Inflammatory bowel disease, there's two types. There's ulcerative colitis and there's Crohn's disease. Does anyone want to take a second and quickly summarize from med students ulcerative colitis versus Crohn's disease? Anyone? Like, just flip that, and that's right. Yeah. So ulcerative colitis is in the name, so it's mostly like colon. It mostly starts from your rectum, and it's continuous fashion upwards. And then for Crohn's disease, it's basically anywhere in the GI tract from the mouth to the anus, and it has skip lesions, which are transmural, so you can have more manifestations. This trial is about ulcerative colitis specifically, and the way that ulcerative colitis manifests, if you think about like the geographical location of it, okay, there it is. Basically from the rectum upwards in a continuous fashion. So it can present with left lower quadrant pain, bleeding, urgency. Those are the typical symptoms that you get with this. So now that we've kind of identified the two forms of IBD, let's do mix-up. All right. So does anyone want to read out question 1 for me? Anyone? Yeah.
32-year-old man is evaluated for relapse of ulcerative colitis unresponsive to increasing dosage of a 5-amino salicylate. Symptoms remitted after 1 week of prednisone. After tapering the prednisone, however, symptoms return. On physical exam, vital signs are normal. Abdomen thrombostatic, with left lower quadrant discomfort on deep palpation, no abdominal guarding. Results of tests for tuberculosis, hepatitis B, virus infection, and stool enteric pathogen panel are negative. That enzyme activity is normal. Colonoscopy shows changes consistent with ulcerative colitis from rectum to the stomach flexure. Biopsy specimens show severe active chronic colitis without evidence of cytomegalovirus infection.
Wow. Okay. Thanks for reading that. So just a few points here. Mix-up does ask about biologics, is my first kind of takeaway from that question. You do get some questions talking about it. They give you a lot in the question stem in terms of they've done infectious testing to rule out infectious causes of diarrhea, which are common in patients with IBD because IBDs can present as flare-ups. So whenever you have a patient coming into the hospital with inflammatory bowel disease, you always make sure that their infections are negative because of the drugs that we use in treatment that could worsen infections if there's any. So I'm glad the infections are out. And then your key point here is they've already defined what it looks like, which is severe active chronic colitis. And so does anyone want to throw out any options that they think might be the right option here? This is a safe space.
I safely have no idea.
All right. That's okay. We're starting something. So anything that you think that is not the answer.
Infliximab TNF alpha inhibitor, right?
Yeah.
Is it whatever AZT thing? Does that have to do with like, is that 6 mercaptopurine?
It's one of those. It's an immunomodulator. Yeah.
One thing, I mean, would you do infliximab and azathioprine? I don't know if like I've seen that regimen for ulcerative. I've seen people just get infliximab.
That is an excellent thought for someone that safely did not know the answer. I'm gonna go ahead and say that is the correct answer. And I will talk about why the other options are not. And there's gonna be another question. This is like creating a base for the talk, and then the other question is also gonna hone in some important points. So this is someone with severe active chronic colitis, and this is someone that we're tapering off steroids. So severe flare, you start that, you want to cause remission. That's your first target. So how are you going to do that? You're going to try to throw in steroids. That's the reason we ruled out all the infectious stuff, because steroids, if somebody has a rip-roaring infection, is not a good idea. And so we're trying to taper them off. Azathioprine is one of the immunomodulators that can be helpful in maintenance. It takes 2 to 3 months to work. So if you're trying to cause remission, because steroids aren't working the best, you need something that is going to both induce remission and help with maintenance. And that needs to be a biologic in this case. So azathioprine by itself is not going to help. It's going to take 2 to 3 months to work, and this patient's going to keep having severe chronic colitis and the symptoms for that long. So this is not the correct option. Then azathioprine and infliximab studies has shown that both of these agents together work better than each agent alone. So infliximab is your TNF alpha. It's basically your first line biologic for ulcerative colitis. And so that and azathioprine, this certolizumab, this is actually a TNF alpha also. So it's a tumor necrosis factor alpha inhibitor, but it works for Crohn's. And the way, if you ever see it on a question stem, C for certolizumab, C for Crohn's. So if UC is the thing in question, don't even think about this. And then multi-matrix budesonide is just a fancy way of saying budesonide. The reason multi-matrix is important is because it's the way the budesonide is delivered to the colon. So it has as less systemic effects as possible, because steroids can come with a lot of systemic effects. But you've already been trying PrED and you've already been trying steroids and it hasn't worked. Hence, B is the best option in this case. The reason I highlighted this enzyme, thiopurine methyltransferase, is because azathioprine, thiopurine analogs, this enzyme helps metabolize these drugs. So if the activity level here was not normal, was low, you wouldn't be able to metabolize your azathioprine. And then you would have more side effects from that drug. And side effects of thioprines can be like, myelosuppression, hepatotoxicity, just generalized bone marrow suppression and risk for infections. So that's something to keep in mind. The question stems really gives you everything you need to know. And so to hone further points in, I have question number 2. And does anyone want to read this for me?
36-year-old man with 5-year history of ulcerative colitis is hospitalized with a 1-week history of fever, tenesmus, diffuse abdominal pain, and 12 daily episodes of bloody diarrhea despite use of oral glucocorticoids. Stool culture for enteric pathogens and C. diff assay are negative. He does not improve with intravenous glucocorticoid therapy. Which of the following is the most appropriate treatment to induce and maintain remission? A. Azathioprine. B. Infliximab. C. Tofacitinib. D. Vedolizumab.
All right. Any thoughts on the answer?
Maybe from school bus. Azathioprine takes 2 months to work, so somehow would be a good agent for injection.
Absolutely. That is a correct answer. It is infliximab. That's your number 1 TNF alpha for ulcerative colitis. Tofacitinib and vedolizumab are also biologics, and I'll talk about them a little bit. Tofacitinib is a JAK, Janus kinase inhibitor, and then vedolizumab is an anti-integrin. And these words can seem like hieroglyphics, but I'll talk about it right now. So conventional therapies that had started a long time back, because IBD is an evolving field. Every other month, there's a new trial with a new drug that comes out, questioning the other drugs and causing improvements in the repertoire of medications that we have. So conventionally, steroids was the mainstay of treatment, and it still is to cause remission. And when you are in the hospital with a patient with IBD, steroids is still what we're going to throw at them. There's all these different options. Mesalamine and sulfasalazine are your maintenance drugs that are still used in mild colitis, or just like, for example, if you have UC with just like a segment of inflammation from the rectum upwards slightly, you can do like rectal mesalamine or just oral just for that area if it's mild. Immunomodulators like your azathioprine are also used on top of that. But when these treatments fail to work and when you need more help for severe treatments, you go to your advanced therapies, which are biologics. Our first line is anti-TNF alphas. They were also there. They were also the ones that came first and have maintained their position in our IBD market. So that's infliximab, adalimumab, golimumab. I put those in so we can familiarize ourselves with these names. Anti-integrins, that's your vedolizumab. This was a really nice trial, the varsity trial, V for V is how I remember it, that helped it like enter the market of IBD. Anti-IL-12, IL-23, there are other cytokines, ustekinumab and mesenchymal. I remember these by the K's in their names. And I remember KK, IL-12, IL-23. Small molecules like S1P inhibitors and anti-JAK are more into the market. They're the most recent medications. But if you see a question stem for IBD, they're most going to be targeting your first line. So only if a patient has trialed the infliximab, adalimumab, golimumab, will you try for the other classes of biologics. And from the questions that I've seen on MixApp, they're usually going to TNF and anti-integrins. You'll see the other ones in the question stem, but usually the first two are the answer if they haven't tried them yet. So that's the point I wanted to make. And then also talking about all of these different drugs is me kind of queuing in our article and saying that new approaches in IBD are needed because there are still patients that, I mean, we see in clinic as well, which have severe or moderate to severe ulcerative colitis that have tried all of these different classes and more, and still haven't been able to get into remission and still are dealing with 12 to 13 bloody bowel movements a day. And I can't imagine how it is to live like that. And so there's always new trials happening, and a lot of different pharmaceutical companies are also trying to bring in new drugs into the market. And we're always open for more options and new studies to kind of interpret. And so Artemis UC trial is the one that I'm going to be talking about. It is a trial on a new drug, and this drug is tulisokibart. Don't be alarmed by the number of words in this slide. I'm going to summarize it in a simple way, hopefully. This is a drug that targets this TNF. This targets this TNF cytokine that I can talk about in this picture. So there's this molecule called a tumor necrosis factor, like cytokine A, and it binds to this receptor on endothelial cells in your GI tract called DR3, or the death ligand. And when it binds to it, it starts this inflammatory cascade and activates all your helper T cells and your type 1 T cells and type 17 T cells to the area and causes inflammation. So bottom line is this cytokine is floating around in our system, binds to these receptors in our colon, and then can activate an inflammatory cascade and can cause inflammatory bowel disease. And interestingly, there's a lot of research going on in terms of the genetics in the IBD population and what genes they have that predispose them to IBD versus the rest of the population. And these two genes were studied in this subset of population. And this is the gene for the cytokine, which is this TNSF15, and then the gene for the receptor. And they found out that patients that have these genes or more of these genes are actually more predisposed to IBD. And so this drug targets this mechanism by which these genes cause inflammation. And so the purpose of the trial was to see if we block this complex from happening and stop the inflammatory cascade, will we be able to cause remission in IBD when these patients have failed other biologics? So that was the point of this trial and what it was trying to get into. Just like a one-liner about this trial, which tells you a lot about the trial already. It's a phase 2 trial. It's multi-centered. It's double-blinded. It's placebo-controlled. And it's used to measure the efficacy and safety of tulisokibart, which is the TLA1 monoclonal antibody. So I know I put in a swim photo because that's how I learned about different phases of different trials from first aid. Do any of the med students know what I'm talking about in terms of like swim and phases of trials?
Step one, has to go now. We didn't have to.
Oh, all right. Oh my God. Yes. Oh my God. Forgot about that part. We are reading big picture things and not in the text. But there's also a diagram here for those that like this kind of way of learning more. But I learned it through mnemonics. I'm a mnemonics girl. So swim. S for phase 1. Is it safe? W for phase 2. Does it work? I for phase 3, does it cause improvement? And then M, how is it in the market for phase 4? And so this is a phase 2 drug. So we've kind of already talked about the safety in a smaller subset of populations to see if this is a drug we can give to more people, and just to make sure safety is our first priority always. And then the next thing is, does it work? So phase 2, which is what this trial is, to see if tulisokibart actually has any efficacy. And the fact that it's double-blinded means that the patients getting the people getting the drug and also the people administering don't know who's getting the placebo, who's getting the drug. And then it's multi-centered across 14 different countries. And so we'll talk about PICO. So our patients are adults above the age of 18 with moderate to severe ulcerative colitis, and it's defined by something called a Mayo score, which I'll talk about in the next slide. So we have patients with moderate to severe ulcerative colitis, defined by the Mayo score, which I'll talk about, and then patients that are dependent to steroids or have had treatment failure with steroids, immunosuppressants, or advanced therapies that we discussed on the previous slide. So these are our patients that we're trying this drug on who've tried other things and it hasn't worked. So this is not a drug that we're using on patients that are completely naive. This is more to test on patients that really need another drug in terms of all of the different biologics that we discussed. The intervention in our group is administering the drug tulisokibart. The comparison is our placebo, and our primary outcome is clinical remission at week 12. And it's defined by the Mayo score, which again, I'll talk about. And there's a lot of secondary endpoints here, like endoscopic improvement, clinical response, symptomatic remission, histological improvement, histological and endoscopic improvement, mucosal healing, and IBD-Q, which is like a survey that patients get on their whole like lifestyle with IBD. And so I'll talk about the Mayo score first, since there's going to be a lot of mention of this Mayo score throughout the study. And this is how we monitor disease activity. This score was actually made by two great physicians in 1987, I believe, and they were running into a lot of difficulty kind of categorizing how these patients with IBD were doing in terms of their response, because everyone has a different number of bowel movements, everyone has different onset of pain, and to kind of put all of the things together, they created this use of this score so that we can better kind of characterize how our drugs are working or how our patients are doing over time. So it has different components. Stool frequency is one of them. Rectal bleeding is another one. The findings on endoscopy is another one. And then your global assessment is our fourth point. For this study, they're using mostly the first three, which is stool frequency, rectal bleeding, and findings on endoscopy. The way that they've defined our population with moderate to severe UC is a Mayo score 4 to 9. So that's pretty high, because the total of this would have been 9. And then rectal bleeding subscore more than 1 and an endoscopic score of more than 2. So moderate disease here and visible blood in the stool for more than half the time. And then clinical remission, in terms of our outcome, is defined as, also per the Mayo score, a stool frequency score of 0 to 1, and not greater than how it started with. So if you started with a stool frequency score of 0 and you were at 1, that doesn't count. A rectal bleeding score of 0 and a Mayo endoscopic score of 0 to 1. So they're really aiming for a lot of improvements through this Mayo score in terms of all three facets of what this score contains. And these are our outcomes and our population. So let's talk about the trial design. Fun fact is, when we were talking about this trial initially and when I was presenting it and when I was going into the weeds of it, there's a lot of interesting things that happens with the patients in this trial and how they've been moved around. So I want you guys to really pay attention to me right now so that we don't get lost. So they had two cohorts that they started with. They had a huge subset of populations, around 130, I believe. I actually have a better diagram in the next slide. Yeah, 135 patients that they kind of put in cohort 1, and around a total of 43 patients that they put in cohort 2. These 43 patients that they put in cohort 2 were the ones that tested positive for the gene testing that they did for the people that were predisposed to a better response to the drug based on the genes that they had for this cytokine. And group 1 was just a bunch of people, regardless of their genetic status. So we had a lot of people in group 1 and then people in group 2. Group 2, there were 135 people that underwent randomization. 67 got the placebo, 68 got the drug. It's probably in very small writing, but over here is what the cohort in cohort 2 that they started with. This is the disease positive patients that they found that had the genetic testing. 42, 21 or so got the placebo, and then 22 or so got the drug. What they found is that they were having a lack of numbers in the patients that were disease positive, and they wanted more of those. So what they did, and I wish I could have reached out to the people in this trial, because the shift here really impacted all of our statistical tests, but they took the disease positive patients in cohort 1 and they added that to our cohort 2. And so what you see here is the disease positive patients from cohort 2 that have been added on to our subset here. And then they redefined what cohort 2 was. So cohort 2 is just now genetically positive patients from cohort 1 and from cohort 2. And cohort 1 is just a mixed hodgepodge of patients that we started with, or the same patients that we started with. Another point, and the reason why I added this slide is because you can notice here that, for example, in our cohort 1, 7 people discontinued treatment. And then even some here discontinued treatment. However, we started with 67 patients that got the placebo, 67 were included in the trial. And so we're reaching at a principle here. Does anyone know which principle that I'm talking about?
Intention to treat.
Absolutely. Intention to treat. Everybody that was in this trial that got, regardless of whether they left the trial, something happened, if they got the placebo or they got the drug, they were included at the end. And I'll talk about how they were included in terms of the stats.
Can I
But-
ask you a question?
Yes.
So the way they ended up doing it makes perfect sense.
Yeah.
One cohort that doesn't have the gene, one
One
cohort
cohort
that
that
does have the gene, and then test them both.
Yeah.
It's basically 2 trials running in parallel.
Yeah.
That's perfectly fine. But my
Yeah.
question is, what was the intention of cohort 1 originally? Why not do that from
So I'm so glad that you asked this because I was scratching my head for a while. Cohort 1 is still a mixed subset of population. It's not the ones that don't have the gene. So they still maintain cohort 1. The only reason that they added more disease positive patients to cohort 2 is when they realized that they might not have enough power in cohort 2 to power like the statistical significance for their test.
Because what were the goals of having 2 cohorts in the first place, if not to have one
Yeah, why
cohort
not
with
have-
the
With the gene and one
Did
cohort
they,
without.
did they clarify, did they leave disease positive patients in cohort 1 still, and they just took out enough
Yes.
power? Okay.
Yes, so people that entered cohort 1, regardless of their gene status, stayed in cohort 1, and they just used the disease positive patients in terms of their analysis for cohort 2. And Ajit and I were going back and forth about this trial for a while because we really didn't understand what they were trying to get to. The only thing that made sense was the fact that they wanted more power in cohort 2 in terms of their disease gene positive population.
Totally. What they ended up doing makes perfect sense. I guess what I'm trying to figure out is
Is why
what was the
cohort one.
intention of the original design in having these 2 cohorts where the cohorts are not differentiated by gene status, they're differentiated by
Who knows?
who
Yeah.
knows. Why have 2 cohorts at all? Why not just have one cohort of patients to randomize it?
That is my bone to pick with this trial. But
I just have one extra question.
Yeah.
So we have patients in the upper right who were
Yeah.
originally in cohort 1, but were gene positive, so then got put into cohort 2.
so
And then the patients in the bottom right who were originally gene positive and knew they were supposed to be in cohort 2. Are we then going to be grouping those patients together in the next
So-
evaluation or outcome?
So basically, just to clarify again, cohort 1 is your mixed subset population, regardless of their gene status. So there's gene positive patients in cohort 1 and gene negative patients in cohort 1. And when these patients were used into analysis with cohort 2, they were not physically removed out of cohort 1. Cohort 1, all of the analysis and all of the safety analysis and everything that was done remained with the patients that it started with. And I think, if I had to go into their brains and kind of hypothesize why they would have done it, it might have also been to see if this drug was generalizable to the disease negative population, to a whole mixed population, to see if they still had the same outcomes there than they did with the disease positive patients. That would be
Not,
what I think.
not to continue to derail you on this subject.
No,
but-
please derail me because
So, did they clarify whether this extra subset was pulled out when they were already doing the statistics? Because it seems like they started with their cohort 2, saw a signal but didn't have significance, and then decided to pull a bunch of extra patients to increase the
Yes.
power.
yes. It was done mostly when they'd already given the placebo and the drug to the patients in cohort 1, and they'd already done it in cohort 2. When they were further along in the study, they realized, hey, I don't think we have enough power in our disease positive population. Let's just group the ones from cohort 2 with this one, and then just have a bigger pool of disease positive patients, is what they were thinking, from what I understood from the trial.
I also just answered my own question. So the top right and the bottom right then are going to be evaluated all together,
Yes,
which I think is just a bit weird because they're separating them now but combine them later.
yes.
So-
And that goes into play when we talk about limitations and generalizability to the population and the way that things are stratified. But this affected a lot of statistical tests and stuff. And this is why the trial became more interesting. All right. So the way data collection was done in this trial was they had assessments of rectal bleeding and stool frequency per daily diaries that the patients were logging in. And then you had endoscopies with biopsies that were done at baseline and then at week 12 so that we can get the endoscopic component of the Mayo score at week 12. So they had these two. When they were gathering data in terms of the endoscopies, they had central readers who were unaware, hence the blinding component of whether a patient had gotten the placebo or they had gotten a drug, to kind of reduce bias over here. And then they also had, if there were discrepancies between the local and central readers, there was like they kind of went by the score based on I think either the local reader score or the first central reader score to be used. Like they met consensus when there were discrepancies. And this is all done to reduce bias. And then the IBDQ is like a questionnaire in terms of how their lifestyle and all the different facets of their life have been affected. And this was administered both at baseline and week 12. So this is how our data collection was done. Let's talk about the characteristics. So also in this table, what I will note is that you have cohort 1, and they've now, instead of calling it cohort 2, they call it patients with a positive test to likelihood response, so gene positivity. So these, as I mentioned, and as we've talked about, this is both cohort 2 and also the disease positive patients from cohort 1 mixed in. And anything that can you guys see anything that stands out to you guys about the population? Or the patients?
Heavily white.
Yeah. And I think this is a lot to factor into the countries that this trial was done. It was done in 14 countries. It was done in Canada, in the US, and Poland. And so I think it predominantly reflects the population in that area. The other thing is, I think if I was to kind of discuss, I think the age ranges are similar across the groups. And then we had other things to talk about, like, for example, the patients that had gotten, there's a lot of patients here that had no previous exposure to advanced therapies. So that's something to note here. And this is consistent kind of through the trials. And there are also patients in the trial that had exposure to more than 2 advanced therapies, and these are our biologics. So this has like a mixed population, which is how our general population looks like too, in terms of there's patients that have no advanced therapy involvement, and then there's patients that have more. So I think in terms of the subset of population, in terms of their IBD status, I think, yeah, it reflects the population. But then if you talk about like, obviously the race, then you have predominantly white people. And this overall, like the population here really tells us about how generalizable the study can be to a general population. And also this is a phase 2 trial, so we don't have that many numbers here. We need more trials with higher power, higher patient population to kind of infer on the generalizability overall. And then I'll talk about the endpoints. So we spoke about clinical remission being our primary endpoint. And the Mayo scoring, and what the Mayo scoring refers to in terms of clinical remission. And then we talked about the secondary endpoints. And I've listed them again, and I'll talk about how they viewed their secondary endpoints in the study. Now we'll talk about the stats. And I'm going to keep it simple and have 3 takeaway points from the stats in the study. The first one was, we already discussed intention to treat. Everybody, regardless of whether they left the study, something happened, there was a bad outcome, they were all included at the end in terms of their analysis. Nobody was lost. The second thing is, I'll skip over the second thing and talk about the third thing actually, and this is the sequential hierarchical testing procedure. This is used when there's a study with multiple secondary endpoints like ours did. We had around 5 or 6 secondary endpoints here. And the method that they used here was they went in a hierarchical fashion, and they went one by one in terms of how they weighted each endpoint. So for example here, your endpoints are symptomatic remission or histological improvement, histological endoscopic improvement. So if a patient didn't meet statistical significance at symptomatic remission, they did not go ahead and then look further beyond that. So they stopped testing other endpoints when the one before it didn't reach statistical significance. And I think this was important to note in this study. So, and this has been used in different studies when they have a lot of different endpoints. The second point, which I'll get to, is the Cochrane mental Hansel test. And I have been calling it the Hansel and Gretel test for the longest time. And so I have a little gingerbread house at the corner of the slide, and I have two famous faces here. Because this trial was a doozy to begin with, but when I was discussing this trial with Ajit, who I hope sees this at some point, this was the exact face he made when he was reading this trial. And when we got to this statistical test, neither of us had heard of this before, and so we were astonished. And we were discussing it, and it finally clicked at 2 a.m. on an ICU night with Nawaz, when both of us were kind of looking at YouTube videos about the purpose of this test. To make things simple, it's just a more advanced version of a chi-test. It looks at the categorical variables, and it's used to assess the association between the two. That's what the chi-square does, but this is a chi-test on steroids, which means that it really adjusts based on our strata. In patients with IBD, especially in a trial like this, when you have patients who've had no advanced therapies, or patients who have had advanced therapies, patients who have had 2 advanced therapies, patients who have had 1 advanced therapies, patients that are gene positive, patients that are not gene positive. There's so much to account into that just a simple chi-square won't cut it. And so there goes our Hansel-Gretel test. And what it does is, and what it did is that it took into account each subgroup. So people in cohort 1 with gene positivity, patients in cohort 1 without gene positivity, patients in cohort 1 that had biologic experience, patient in cohort 2 that did not, and they did separate relative risk or association testing between each, weighted them all together, and then pooled that data for us. And in cohort 2 or disease positive patients, we already have a subset of patients that are disease positive. So it had less strata to deal with. The only thing it was adjusting for was whether or not they had exposure to advanced therapies or not. So this test kind of pooled all of this data together on a weighted basis, and then gave us our final outcomes of association, which we see. So overall, it's a pretty cool test. And I kind of looked back at different IBD researchers, like the varsity trial and different trials that have been, and this test has been used in those as well, and basically is used anywhere where you have a lot of different groups with a lot of different strata, and you just need a test that will account for them. And so pretty cool. Thanks to Nawaz and Ajit. Now we'll talk about the results, and I'll talk about what this Hansel test did as well. So results in cohort 1. Does anyone want to kind of infer what they see? The blue is the drug, and then the gray is the placebo. In terms of our primary endpoint, how do you think we did?
You're pretty good.
I think it looks like we did.
Good.
I think it looks like drug good. In terms of our endpoints, I'm also pretty surprised that, okay, our drug is doing better than our placebo. This percentage difference here was pulled in by this Hansel test that we have here. And then you can take a peek at the p-values as well. What do the p-values tell you?
Statistically significant.
Yeah. And so what do we infer from? Do we think all of these are statistically significant?
Yes.
Yes, because our p-value is less than 0.05. And so in cohort 1, this is our mixed subset of the population. We're seeing, yeah, we had a pretty good response, 25% difference. Our p-values, everything is significant. So our endpoints our secondary endpoints are looking better as well. And this tells us that regardless of whether a patient was gene positive or gene negative in this big pool, the drug still acted pretty well.
What is the IBDQ?
This is our IBDQ survey. It's like a
So it's like
whole
a central
demographic
analysis.
survey. Yes. That
Oh,
patient.
probably isn't that great.
Yeah.
One quick question, but just like, so what was defined as symptomatic remission? Because I guess like what I'm seeing here is like because they're going down hierarchical, right?
Mm-hmm.
Through endoscopic improvement, then you have clinical response, which is like something has changed. And then symptomatic remission is actually the one where we start to lose people.
Yeah.
And it's the closest to not being statistically significant.
Yeah.
So it's like, that's actually the first one that's talking about patient symptoms.
Yeah.
With very, very low sets, and like confidence interval is like 2 to 25.
Mhm.
So I don't know, just pointing that out.
Yeah.
Just a thought.
And I think another thing to consider in these patients is that patients with IBD are living with, chronic pain. And that's another thing to factor is even if we have endoscopic healing and mucosal healing, these patients are still going to be in pain. So we might not be able to get them 100% in term like clinically or symptomatically free of any pain or any discomfort. And so that's why like the Mayo score is important too, because if we were to go by patient symptoms or just their clinical status, we might not be able to kind of be able to reach a consensus on what drug is working or what drug is not working. And that's why it was lower down on our hierarchical testing.
Where is the Mayo score implemented? Is it in the clinical response or the?
It's in the clinical remission, because clinical remission is based on a Mayo score improvement throughout each of the
Throughout each
quadrants.
phase.
Yeah.
So I just want to take a moment to make a small correction. So.
Yeah.
So we did this secondary endpoint hierarchical testing.
Yes.
Where if the finding with this secondary endpoint we're looking at was not statistically significant, then we would
Stop. Yes.
And then in front of us, we see the results and all of them are statistically significant. So just we never stopped is
For cohort 1.
for cohort 1. And so we actually didn't at any point lose patients along the line.
That's helpful.
We were just looking at, so if you see like symptomatic remission, that represents 6 out of the 68 patients who had symptomatic remission versus 19 out of the 67 patients. But I just wanted to correct that we didn't lose patients. Each of these bar graphs is representing the same patient cohort. And then I just wanted to ask broadly, you guys have a sense of like why hierarchical testing or we're just moving now, but why was that idea proposed?
I think because of the amount of secondary endpoints that they had. And I think it's because of how they weighed the importance of each secondary endpoint. Like their endoscopic improvement was the first secondary endpoint that they were targeting. And they had, like, for example, the IBDQs, the survey, for them, it was like the least kind of reliable in terms of the drug efficacy. And that's why it was like lower down on their list. So they were like, if we're meeting, and also this was a phase 2 trial too. So they were like, if it's working and we're showing that it's working, we don't have to show that it's working on each facet of IBD as long as it meets our big brackets, which is overall clinical remission based on Mayo scoring and endoscopic improvement and clinical improvement. So they weren't hoping to kind of target each thing, but just overall to see like, hey, and if they found, for example, that they were meeting statistical significance on their first 3 secondary endpoints, they were happy with that from what I got from there.
And the other thing I wanted to just point out, like what happens if you take 200 like secondary endpoints? Like how many of them would you expect to be statistically significant on average?
Like 10.
Like if we're looking for p-value of 5%, in which 5% of the time we find a difference, a statistically significant difference in a random sample set, and we take 200 endpoints, how many are we going to find are different?
Well, guaranteed by 10 figures.
Yeah.
Well, so 5%. You take 100, and on average, if you take a group of like the population and say which like part of the population is different in ages, and you take like 200 different endpoints, five endpoints of those are going to be statistically significant. I hope that makes sense.
Yes.
And so like what there is there's something called the Bonferroni correction, where you basically like divide the p-value by number of outcomes you're having. And so, for example, if you do like 200 or 100 endpoints, then you divide the p-value by 100 and you would want a p-value of 5% in all of those findings. You want a p-value of like 0.005.
Interesting.
I don't know if that makes sense, but basically I wanted to point out that's why they limit how many secondary endpoints you choose, because on average, a lot of them, if you take a lot, then you're increasing your likelihood of finding a statistically significant result when actually there is a difference.
Oh, that's interesting. And then these are our results in cohort 2. And there's something to talk about here, but I'm going to let you guys find it. Okay. Anything sticking out? How do you think our drug did here?
That's good.
Why do you say that's good?
I mean, the clinical remission is still significant, but it's not as significant as before. And then the secondary endpoints none of them are significant.
Okay.
So they just don't put in the design.
Yeah.
Exactly. Both
And the
points.
one that
Yes.
p-value has a
Yes.
confidence interval. that
Yes.
counts.
That's insane.
Yes. And this actually made me present this trial because I was not going to because of
Yeah,
how
look at the
confusing it was.
pillars.
So yes, I love it. I love that we got to this conclusion and this is, my talk is concluded. No, I'm kidding, it's not. But this is what I wanted to point out, the fishy business, which is that there's just suddenly no p-values reported for some of these tests. Our confident intervals are all the way ranging from all the way between -2 and 36 and 0 and 42. And we're not meeting statistical significance. And so I looked into it about why we weren't reporting p-values and kind of what happened during this time. And the rationale behind it for the trial was that the confidence intervals weren't adjusted for multiple testing because this is our cohort 2 or gene positive population. And because of the mixing around that they did, they couldn't adjust the confidence intervals. And so they didn't report the p-values. And so when I don't see p-values, I don't see significance. When I see a confidence interval looking like this, I don't see significance. So this I will buy, but this is shady. And this is something to notice here. And this is why Journal Club is fun. All right, so it worked in clinical remission, but
Is that because the testing, so the first one's not significant until they supposedly are stopped?
It's-
and the other.
it seems like they still tried to adjust. They still tried to get the p-values, and they were using this new combi method to try to get them, but they just couldn't adjust these p-values with these confidence intervals. But it looks to me that they tried to, because at least I think they tried for the first two, the clinical response and the symptomatic remission, from what I inferred from the trial. I really wish I could pick the brain for the people that did this trial. I actually sent an email, but I didn't get a response back. I don't think I'm going to. But okay, glad we spotted that. And then we'll talk about safety, which is mostly a phase 1 thing. But in terms of the adverse effects that occurred, what does this look like to you guys? What do you think? Anything that pops out in terms of the adverse events?
Thanks for knowing that.
Yeah, thankfully.
Well done, man.
I'm glad about that one. And then,
You might have adverse events in the placebo, the
I mean, they
placebo
both
version.
seem to have it.
Yeah.
Not the same.
yeah, no, yeah, exactly, yeah.
Wait,
The,
some of it, oh, okay. Wait, what's the difference between serious adverse event and treatment like that?
I think that's a great question. I'm not exactly sure. I think a serious adverse event is just a really serious adverse event, and treatment related would be just secondary to getting the treatment. For example, like, with your biologics, like an infection secondary to getting the biologic, or someone, I think that's what I would infer, like a terrible infection after starting that, or like an infusion reaction or something like that.
Well, they both got infections.
Yeah. And if you look here, the adverse events occurring in more than 5% of patients is what I kind of honed into, which is UC, or like the fact that they still couldn't meet remission of UC, or their UC flared. This is around 9 in the placebo group, and then around 1 in the tulisokibart group. And then both of them had some patients with got COVID, which I don't think is a drug thing. I think it's a world thing.
When was the trial done?
Last year. Okay, so this is about safety. Limitations, there are many, and I want to open the floor because I want to see what you guys thought, because I already have my thoughts about this trial, which I've been mentioning throughout, but what are like some main thoughts that you guys took away from this?
Well, it's interesting because the proposed mechanism of how this drug works with the gene positive patients showed no significance. But when you put together a big enough group and enough like strata of those groups, like all of them were saying, all of a sudden, all of them are now statistically positive. So it's just like, did they just have a big enough number that the data looked okay?
Yeah.
Because in the actual proposed mechanism of action, they showed no effect.
Yeah, I think that is a great point, and I think that's why more numbers are needed, because we need to we need more power. The study needs to have more power to kind of see if it's actually statistically significant or not, in terms of the effect of this drug. But I found it interesting that our cohort 1, as Michael mentioned, we did see a good response, and that means that regardless of their gene positive status or not, this drug can actually work. And it did meet the primary endpoint within 12 weeks. And the reason that I'm talking about it meeting the primary endpoint is that there's been I'm not going to talk about this too much, but there's been other trials like the Varsity trial in the past where they've put adalimumab, which is our TNF, and then vedolizumab, which is our anti-integrin, head to head and seen who meets clinical remission at 14 weeks first. And it looks like our drug here did a bit better in the first cohort than these other drugs did to meet clinical remission at the point of 14 weeks. And this is something we were pooling together. So there is scope for this drug. I think there just needs to be more higher powered studies and more to kind of investigate this further, and possibly studies without that much moving around of cohorts, so we can actually have clear strata, we can have our p-values, we can do our statistical test properly and infer more effects from
Can
that.
you go back to the
Yeah.
slide for cohort, the second one with the cascade of secondaries and the
Yes.
primary? This is for cohort 2, right?
Yes.
So it was statistically significant for the clinical remission. Let's not forget that. It was not statistically significant. So they did meet primary endpoint in
Yeah.
cohort 2.
Yeah.
And if you look at the paper for the folks with, I'm gonna start calling cohort 3, but everybody had a gene positive, they also met their primary endpoint for that. So actually they met primary endpoints across the board.
Yeah.
In cohort 1, cohort 2, and what they should have called cohort 3. So they didn't meet their secondaries here, but that's probably because they weren't powered for these secondaries. I mean, look at the size of these cohorts, it's so small. I'm not terribly shocked they didn't meet significance. Does that mean there's no difference?
Yeah.
Maybe, who knows? So I don't know, devil's advocate, y'all. I mean, this may have been not the best study design in the world and may have had some quirks along the way, but this is a new class of medicine for a disease that's really hard to treat.
Yeah.
Then met primary endpoint
Yeah.
in multiple different analyses of multiple cohorts. Like, I don't know, I think it's still pretty good.
I am glad you said that, because on discussion with some IBD people that are looking for this drug to hit the market, I spoke to one of the hub IBD specialists because I wanted to gauge his brain on what he feels about this drug and what his colleagues are thinking about this drug. And he is super excited for it.
Yeah.
He said that, as I mentioned earlier, there's so much difficulty in meeting remission for these patients, and all of our drugs are failing to do so. We're always open for more approaches, but as Dr. Glazer said, and as Michael said, we just need more power and we need a better population, and we need clearly designated cohorts so that we can infer statistical significance from that. But the world of IBD is booming and it is exciting. And the takeaway points from my talk is, oh yeah.
It's like, I was wondering if like the control group got the best available treatment. I guess like there's a significant chunk of them that have had 0 advanced therapies filed. And is it really ethical for someone who has an AS score from 4 to 9 to go 12 weeks without any advanced therapy?
That is a very important thing, and I'm glad that you mentioned that. And I think over here, and you can tell here that these patients oh my god, I have it, man. The patients that have been getting the placebo, if you see their UC and you see kind of like the flare-ups with their UC, you see that they're having more flare-ups. And so that was taken into account. The fact that if we're not giving them the treatment, they're not going to get the response as our other population is. What I think is the patients, for example, if someone was on infliximab, they were still continuing their infliximab medication. And that's why we adjusted for the different strata. Because if a patient was taking, for example, infliximab, if someone was on vedolizumab, their medications were not stopped. This drug was added on top of that. So did they kind of lose out by not getting benefit from this drug? Sure. But was something taken away from them? No.
They're still getting standard. of
They're
care.
still getting their standard of care.
Their standard of care, but so in the actual population, I think what you were asking about, there's a number of people who haven't had advanced biologics, but that doesn't mean that they're not on like mesalamine or
Yeah,
something else.
they must be
Even
on.
someone with like, who's getting
Yeah.
infliximab at the start of the trial.
Yeah.
And you're experiencing symptoms, severe symptoms.
Yeah.
over the course of 12 weeks.
Yeah.
Is it, as a clinician, you would add. like,
And they
yeah,
did. And they did. The
We have to
patients
assume
that
they
were,
did at least. I mean,
Yeah.
were they getting mesalamine, they switched to azathioprine, who knows?
Yeah.
I think we have to assume, when they put people in the placebo, it's usually usual care. So we don't have enough details on this individual
Yeah.
to know why are they still at 0 advanced biologics? I don't know, but we have to go off the assumption
Yeah,
of what the trial says that there is usual care. And is it bizarre? Maybe. Under scrutiny,
yeah,
might it have been reasonable? Hopefully.
yeah, yeah. I mean,
Some
cause,
are arguable.
'cause, you know, like, I feel like even with these trials and even as physicians, we always like do no harm. You know, so I think like I'm assuming their intention was that I'm assuming the physicians that were taking care of those patients did do the standard of care because that is what's fair for the patients. But I think that's an excellent point to mention. And that's why IBD trials are interesting.
You'll notice in a lot of studies too that they'll cut off if they realize that.
Yeah.
Standard of care was better. for
Yeah.
whatever reason that they're
And-
not, So.
And there were patients in the middle that, for example, here, patients who discontinued treatment or required rescue therapy they were classified as our non-responders here. And if there was any missing data, for example, somebody in the trial was having severe UC flare-ups and needed more, and they just needed more rescue therapy, needed a biologic on top of that. If they started with like a severe Mayo score just on mesalamine, for example, they were then picked as a non-responder when they were like computing all of the analysis together. That
It's the
helps.
intention to treat.
It's the intention treat. Like the data wasn't missing. It was categorized as non-responder. So we had a place for them. They weren't lost. And then takeaway points is genetic testing is cool. They found a drug, they found out what it targets, and they target the mechanisms. There's actually a lot. There's one happening in Penn right now, which is they're testing an IBD population versus our normal population and looking at the difference in their genes. And this is like a study that's going to go on for years. But then overall, we're going to have like a lot of genetic markers that new biologics can test, just as this one. And then this drug indicates scope. This trial indicates scope, which is exciting. The fact that we met our primary endpoints, there's room for more studies, and hopefully we'll meet secondary endpoints at that point, and we might see this drug on the market in a few years. Who knows? And then this Cochrane-Mantle-Hensel test, I'm actually a fan now. I was confused before, but now I kind of like it. And I think that if there's more IBD research in my future, which I hope there is, I will be looking into this more. And multiple endpoints, sequential hierarchical testing is useful because otherwise you're just down a hole of your 17, 18 different endpoints. And what's the point if you're not meeting statistical significance? There's a lot of info in hidden P's, and I'm so happy you guys picked off the fact that there were no P values because that's something that we should always watch out for all the trials. But that was it. Thanks, guys. I hate this trial, but because of how much I had to go back and
Figure out.
I was like, what are
Well,
you
you made
doing?
a really complicated trial.
I'm gonna try to get into this.
I wish she was here.
I know, where was she? She was trying to. I think she missed all the GI journal clubs. Really quick on one. Yeah. The hour.
He just wants to like.